So you have studied Ayurvedic medicine and these years take a major part of your life. Once you become a doctor, you are committed to healing. And to be a great healer, learning has to become a never-ending pursuit in your life. So doctor, what are you doing to continue this learning?
A very warm welcome to all the doctors, students and practitioners for this AACHAARA Rasayana.
Learning experience for everybody, even for me also, isn't it? So there is no end for learning. So that's what actually I believe.
Today's subject you are given is psoriasis.
Clinical dermatology.
If you use Vamana on yourself first, then you will believe that it will help.
Spending few hours with a scholar is equivalent to months of time spent reading books. In the name of AACHAARA Rasayanam, we are bringing excellent minds on Ayurveda with rich expertise in clinical practice. The purpose of this initiative is to guide and uplift the confidence and clinical expertise of every Vaidya. There is a saying, if you cannot be a king, the next best thing is to become a healer, because you are changing people's life, and that is the power of a Vaidya. AACHAARA Rasayanam is a Ayurvedic practitioners only CME program initiated by Sitaram Ayurveda's 100th year celebration through Sitaram Research Foundation. Sitaram started its healing journey in the year of 1921. Being a pioneer in Ayurveda, Sitaram extends the healing powers through a state-of-art GMP certified manufacturing plant, government approved R&D laboratory, super specialty Ayurveda hospital, and an NABH accredited Panchakarma retreat. By attending AACHAARA Rasayanam, you will get the opportunity to get valuable insights on clinical practices, various methods and techniques prevalent in the Ayurvedic medical fraternity from the best scholars. You will be receiving the show notes, certificates, webinar recordings, and the latest updates on your email and WhatsApp. To receive latest updates and newsletters, please send a text to 89434 41881. For more details, log on to our website www.sitaramayurveda.com. AACHAARA Rasayanam. Great practitioners invest in learning.
A very warm welcome to all of you to AACHAARA Rasayanam, a weekly CME program initiated by Sitaram Ayurveda for its 100th year of celebration. And today the topic of discussion is coronary artery diseases with special respect to hypertension. And the speaker today is none other than Dr. Muralidhara Sharma sir. He is a professor emeritus from SDM College of Ayurveda and Hospital. Many of us directly or indirectly are indebted to Sharma sir for his teachings. And it's not just a theoretical aspect, we are going to have a lot of clinical expertise. As we all know, if any of you have known Sharma sir personally, we know that the kind of patients that are coming and the expertise that we can learn by being with him. So now, because of the pandemic, we have the beauty of technology. So we are trying to utilize as much as possible by bringing all the best minds in Ayurveda here. And the moderator today is Dr. Sreejit. So now I hand over the session to Dr. Sreejit to continue. And then Dr. Sharma sir, thank you on behalf of all the students here, all the doctors here, and on behalf of Sitaram Ayurveda for being part of this session. And it means a lot to us for being part of this AACHAARA Rasayanam.
Namaste.
Dr. Sreejit.
Yeah.
Thank you. Namaste.
So very welcome to all the doctors here. Thank you, Dr. Vignesh, for handing over the baton, and I won't keep it with me for long. Welcome, Dr. Amnan sir also, and everyone, all of you are very important for us. So for me to start with, it's a great honor to be the moderator, and my role is very meager and minuscule. I understand that. My task would be to make sure that I hand over the baton to Dr. Muralidhara Sharma sir. I am a beneficiary of his teachings because his teachings have come to me through Dr. Ravishankar Parvaji sir, who is mentor of hundreds of us. So typically I am in a position that I am in the presence of the mentor of my mentor. So anyway, I think let us get into action, and that's what we're looking for. I would ensure that my involvement would be very minimal, and the entire proceedings, let it happen with the teachings and blessings and experience from Dr. Muralidhara Sharma sir. Sir, all over to you. We are eager to learn and reformat our understanding on this topic. Over to you.
Thank you. Thank you. I think I'm audible.
Yes, sir, you are very audible.
Are you able to see my screen now?
Yes, sir. Sir, if is it possible to enlarge? Yes, all good, sir. All good, sir.
Okay. Now I think it's okay. Okay. Thank you. Thank you, the organizers, for giving me an opportunity to be with the scholars on this day. Now, I'm supposed to talk about hypertension and coronary arterial disorders in terms of whatever my clinical experience is. Of course, before going into the real clinical issue, we need to have some view about these diseases, particularly hypertension. Hypertension is an enigma. Enigma in the sense it is something which is not really understood, and it's a very new concept as such. History of hypertension is quite interesting. See, till about 1896, the blood pressure measuring was limited to only laboratory animals, where a manometer would be directly inserted into the vessels, and then the pressure would be recorded. After William Harvey's invention about the circulation, till then that blood pressure was not really monitored. And in human beings, in living human beings, that was not possible. Only in 1896, a cuff-based sphygmomanometer was invented, and from that day onwards, measuring the blood pressure in a living person would have been possible. But still, the real standardization and definition of the systolic and diastolic blood pressure was done by a Korsakoff, who is still now, when we record the blood pressure, we use the term Korsakoff sounds as you hear the sounds. So that's the credit given to that Russian physician, and it was only in 1905. And even at that period, the importance of that in the disease conditions were not really understood. This was limited to laboratory experiments like recording the blood pressure, and the definition of a diastolic and systolic blood pressure came in 1900 and 1914. In between that, there was some idea like there is a relationship with the diseases and this blood pressure, and hence they had now classified, the physicians had classified, like there is an essential hypertension, something like disease, a disease which could be produced due to increased blood pressure, and the term malignant hypertension came in during that period. But still, there are many loose ends which were not really understood properly at that time, and its real clinical utility came in only much later, and it was only in 1970s when 1940s, that American President Truman, he enacted a law related to the study of hypertension and its relation with the heart as such, and that is considered as the Framingham Heart Study, which is still a benchmark. Even now, it's considered as a benchmark where the risk and the disease importance, the blood pressure, this was really presented in a organic manner or in a very standard protocol, and this has become a standard, and the whole history of whatever we say as hypertension and its related diseases and importance, whatever we now have that clinical idea is just around only after 1948, developed after 1948. Up to 1948, the whole issue was somewhat vague. Relation with the hypertension and the diseases, those issues were more vague, and whatever that current concepts about the hypertension and its importance in the disease management and its importance in the clinical assessment, those things are just around from 1948 to now is not even 100 years old. So something within that, it's a relatively young disease from that point of view. Anyway, now when it comes to the question of what's the normal blood pressure, what should be the ideal normal blood pressure, there is again a lot of confusion about that. The issue is the normal blood pressure was standardized at a different time period, and that kind of a concept of standardization and fixing a standard came in from 1970 onwards. And during that period in 1970s, a diastolic blood pressure of more than 105 was considered as hypertensive. Whereas during the time period, there were many revisions, and the latest is at present, so we will not go into much of the history part there. As per the American Heart Association, which is considered to be the standard, the latest standard would be a systolic blood pressure of less than 100 and 120, and diastolic pressure of less than 80 is considered as normal. And the classification now is, if it is between 120 and 129, the systolic blood pressure, then it's considered as elevated, and that's you have a yellow sign. That means you need to be cautious. If the blood pressure is in between 130 to 140, then it's considered as high blood pressure. This is the latest one. And of course, if it is more than 140, it's considered to be stage 2 hypertension, and then more than 180 is considered as a hypertensive crisis. This is how it's classified now. But as far as the real issues are concerned, there are a lot of confusing issues. And particularly in India, if you assess the blood pressure of almost blood pressure of the general population, you hardly find any person who has that blood pressure standard of 120/80. Very few persons could be there, maybe less than 6% of the total population. Whereas on an average, we will have a blood pressure of 140/80 or 140/90 as the average blood pressure. And in my clinical experience, what I have seen is a diastolic pressure of more than 90 only would be having so-called risks as such. Whereas the blood pressure of less than 90 millimeters of mercury in diastolic pressure, in the clinical conditions, it may not be considered as a abnormal. Of course, this kind of an idea is not only mine. Very recently, just a few months back, European Medical Association has given that standard, and according to the European Medical Association latest this guideline, 140/90 is considered as a normal blood pressure. So as far as the normal blood pressure is concerned, there is a lot of confusion about that, and those who follow the American standards, it's about 120/80, and by making that 120/80 as the criteria, you are making a large chunk of the population as diseased persons. And there is, I think I should not comment on that, but there is some commercial interest. Every time the standard of the blood pressure is reduced year by year, or maybe once in certain gaps of time, there is a huge changes in the market value of the pharmaceuticals, and some new drugs coming, new antihypertensive drugs coming up, and then these standards reducing. There is a linkage. So there is a lot of opinion that there is some commercial interest, and it's not really scientific. Anyway, I will not go into that part. But from the clinical point of view, there is some confusion, and from our point of view in the clinical issue, we may limit to 140/90 as the standard blood pressure. Moreover, recording the blood pressure in the clinic can produce a lot of confusion. There is one standard is white coat blood pressure. White coat blood pressure is once the patient comes to the clinic, after he sees the doctor, there is a possibility that the blood pressure may raise. Even otherwise, even if it is not so, the blood pressure is never constant, and on an average, whatever we see is the graph here. This an average is a fluctuation of the blood pressure in a normal person. This red band shows that normal blood pressure ranges, which can occur in the normal conditions during the daytime, during the physical activity, and hence simply depending upon a single reading of the blood pressure often can produce more confusion, and ultimately what happens is we make a large number of population as diseased, name them or classify them as diseased, and make them dependent on the medicines. Now, the next question is why the blood pressure has to be important. What are the possible complications? After all, because you have a confusion, what happens? Now, based upon the statistics, now these are all the statistical observations. The life expectancy of the persons with a recorded hypertension is supposed to be reduced due to some of the unexpected complications as such. And it's like in females, the life expectancy of a hypertensive compared to the normal blood pressure, the difference is around 2.3 years, 2.8 years as such. This is what seen as such. Now, in the graph, what you see is the percentage of people who have developed some complications. This black color suggests about the persons who might have developed complications which we consider as the cardiac pathologies or maybe cerebrovascular accidents, stroke, etc. The interesting issue is, if you look at the graph, the complications, whatever we consider as the complications like a stroke, MI, myocardial infarction, coronary diseases, etc., they would occur even in a person with the normal blood pressure, and the ratio is almost same. The difference is not very huge as such. In the females as well as the males, the ratio statistics would say as such. If it is around 2.8% of the people, like you may have a myocardial infarction in a normal blood pressure, it is a 3.9 in hypertension. So to say that this is about the females, and similar issue is in the males too. Now, to say that hypertension is the lone cause for the cardiac pathology or for any of the other complication also is not true. At the same time, it cannot be neglected. So that's why I consider the hypertension as an enigma. Now, as far as the other complications which can occur due to hypertension, as per the established concept, is the major chunk of these would be of cardiovascular complications, which among them a good number is coronary artery disorder, as well as another of the issue is left ventricular failure, which can occur. Then retinopathy is again a larger number of patients. This resulting in renal complications, which could be of any category, a creatinine values being just raised, or a renal failure, proteinuria, or a cerebrovascular accidents. These are the possible percentages of or possible distribution of the complications in male and female. Comparatively, as per the statistics, the risks are lesser in females than the males. Then, as per the cardiovascular mortality, the cardiovascular mortality is increased due to blood pressure. This is what same. But again, there is an enigma. A cardiovascular mortality in a normal pressure, where the blood pressure is 120/80, it still is almost just half of what we see in a patient with the stage 2 hypertension. In a stage 2 hypertension patient, it's around 2.05, whereas in a normal person, it's around 1. So the blood pressure is, or hypertension is responsible for increasing the cardiovascular mortality in a statistically significant number of patients. But the other way, maintaining a normal blood pressure doesn't give you a protection or doesn't give you a guarantee that you will not have a cardiovascular complication. So cardiovascular complications can occur in other ways. Of course, now there is another view, like it's not only the hypertension, the cardiovascular coronary risk factors could be related to many other collaborative factors or coexisting factors, and the other factors which are now considered as a high cholesterol level, high density lipid level, smoking, diabetes. These will be having an additional added value, and a person who has all these, then the incidence of along with the hypertension plus any of these variable factors. If these factors are involved, then the possibility of coronary risk could be more, whereas if any of those are lesser, then comparatively the coronary risk would be lesser. So ultimately, the issue is it's not hypertension alone. The other factors also would be having a major role to play in the end result or the complications which can occur as such. Now, as far as the cause of hypertension is concerned, there is again a lot of theories, and most of the theories would be having some confusion or some extraneous interest. Now, for the sake of being brief, I would just put the history or maybe that the causes of hypertension. At one stage, cholesterol was considered as a cause of hypertension. Up to around 1950s, late 1950s, it was considered as cholesterol. Then later, from 1950 onwards, in the later half of the 50s, there was a shift to low density lipid. Now, of course, whether which is true, which is correct, which is wrong, we will not go into that part. But there is a basic issue. Once the era of clofebrate, one of the drug which was used for reducing the cholesterol, and its patent period was over, then a new drug was statin. When it was introduced, there was a shift to low density lipid as the major source of hypertension. Now, whether this is purely guided by the commercial interest or whether there is a real scientific issue, there is a big question mark, a debatable point of view. I will not go into that controversy, but I am just sensitizing that there is a controversy, and that controversy has to be kept in mind when we deal with the patients. Now, other causes of the hypertension, the one very popular theory is about the cholesterol and the lipid, the metabolic causes. In addition to that, the other causes of the hypertension are stress is supposed to be one of the causes of the hypertension. It's well known, physical as well as mental stress. It can produce the hypertension, and this again is a issue, controversial issue, like whether it is really stress which produces a hypertension, or whether a patient of hypertension would have a stressful behavior or stressful personality. That's another of the controversial issue. I will try to deal with that issue again later in the later half of the presentation, like that too, some of the other issues. The important factors are physical stress. So those, and of course, mental stress is also equally important. Mental stress is supposed to be more responsible than the physical stress to produce a hypertension. And there are certain occupations also, depending upon the occupation, particularly those occupations where the person would have a lesser physical activity, sedentary, and more of a mental stress. The incidence of hypertension will be more. And interestingly, incidence of hypertension among the medical practitioners is higher than the general population. That's the other factor also. Now, another of the theory now is about the oxidative stress, which is now gaining a lot of value. A new theory. Oxidative stress is one of the metabolic products, like the oxidant radicals. They tend to produce the damage to the cells, and then when they produce the damage to the cells, it can produce multiple issues, multiple complications. And one of the triggering factor for this oxidative stress is obesity as well as psychological stress, of course. And it's also supposed to be related to consumption of the sodium. These are all the some hypotheses, like, and of course, these days to speak about antioxidants has become a fashion. And of course, from Ayurvedic practitioners' point of view, we have lots of drugs which are claimed to be antioxidants as such. So the antioxidants supposed to be a panacea for all the diseases, like. So I'm not going to that part of the controversy issues, but just I am referring to those issues. And that to speak about oxidants and antioxidants has become a fashion as such. Now, another group of the hypertensive patients, which we consider as a secondary hypertension. Secondary hypertension in the sense that there is some other real causes which are triggering them. Among those secondary hypertension causes, a major chunk is about aldosteronism, where there is adrenocorticotropic cycle or axis has become abnormal, and hence there is a increased aldosterone levels, or renal pathologies, tumors of the adrenal gland, and then cortisols, steroids being either administered as a treatment or steroids which could have been produced. These are supposed to be the other causes of the hypertension, possibly. And in addition to that, there are still many more which could be a cause for the hypertension. And hence, in such conditions where there is a primary cause which is different from the real presentation, and hypertension is a presentation of some other disease condition, whole approach to the treatment would be different. Whatever we are discussing today, we will be discussing about the clinical management. Our focus would be only on these essential hypertensions, or where primary hypertension. Secondary hypertension, it requires some more of the information about the primary disease, which I think I would not deal with in the today's presentation as such. Now, certain other theories or certain of the publications which are already there quite important, which we should know, is the secondary hypertension causes. Among the secondary hypertension causes, another new concept which is coming up is the medicines, drugs which are being given to the patients could be a cause for the hypertension. Among those well-established causes which can trigger the hypertension are the estrogens, oral contraceptives, which have now become quite popular. Then illicit drugs like amphetamines, anti-inflammatory drugs which are quite frequently used as a psychiatric drugs used in the psychiatric medicine, and the sympathomimetic drugs which are again quite frequently used. These and steroids which are commonly used, they are known to be causes of the hypertension. At the same time, the research articles, they have attributed herbal drugs also as a cause of hypertension. I think we need to be, Ayurvedic practitioners have to be sensitive about this kind of a issue. It's often claimed like the herbal drugs also are considered to be the cause for the hypertension. Now, another category of the hypertension is a malignant hypertension. The malignant hypertension is irrespective of the cause, whether it's a primary or otherwise, whether it's produced due to the drugs or otherwise. When a hypertension produces damage to the different organs of the body, it could be the kidney, heart, or retina, brain, or so on. That condition is called as malignant hypertension, where the raise of the blood pressure is very rapid, and this is defined as a hypertension which can produce a cellular damage to the body at any target organ area. Now, interesting issue. Now, this just I have casually collected from a publication. When it comes to the question of 15 things which can increase the blood pressure, the major issues are the same which we have already considered, like behavioral aspects. But one thing which is claimed is your doctor. A patient, a person who goes to a doctor, there is a high possibility that the doctor himself could be a cause for the hypertension in both the ways. Of course, it could be like simply because the person has gone to a doctor, there could be a stress. The other way, the doctor's reaction to the patient also could be a cause for the hypertension, so on. So, socially, this statement is a quite popular statement, and being in the profession, we need to be sensitive about this issue also. Doctors can be cause for the hypertension. Now, in brief about what should be the standard management as per the standard protocol given by as guidelines, standard guidelines world over. Now, this is what's given by the WHO as the 2017 latest guidelines for management of the hypertension. Not the question like whether these are really followed or not. Now, to make it clear for all of you, the same chart I have put in 2 slides so that you will be able to make out clearly. The standard protocol is if the blood pressure is in between 120 to 80, the protocol is do not give any medicines, no question of drugs as such. Promote the optimal lifestyle habits. Ensure that the patient doesn't have a lifestyle factor which can trigger the hypertension, and regularly reassess. This is the guideline which is there. If it is in that elevated category, 129 to 80, then non-pharmacological therapy. Non-pharmacological therapy is diet and exercise. We'll come to that part. And reassess in 3 to 6 months. This is the standard protocol which is given by the universal medicine practice. Naturally, the question comes in like whether it's really being followed by our fellow practitioners in the other system or not. That's not the question. I'm not criticizing that part, but this also is one of the issues which we need to be aware of. If the patient has a stage 1 hypertension that's in between 139 to 90, then again, the preference should be a non-pharmacological therapy and reassess. This is what the standard protocol says. Again, I stress upon this part, like this is a universal guideline which is to be followed by the contemporary system of medicine and the latest. Unfortunately, these guidelines are not practiced, not followed in the clinical practice, and there is unnecessary over prescription of the drugs in the practice, and of course that gives a huge scope for Ayurvedic doctors to intervene in this issue. Now, anyway, that's the other part. Then, if the blood pressure has produced some increased risk. There are some increased risk factor for the coronary pathology like hypercholesterolemia or smoking habit and so on. In that condition, it again, you may have, there is no need of a direct medicine for that condition too, but you have to assess in a shorter duration, like once in a month, and the BP goal, whether it's met or not. If the BP goal is not met, then you think of the drugs as such. Medicines are to be prescribed only when in a stage 1 hypertension, only when there is a additional risk factors like particularly hypercholesterolemia or the smoking as a habit or other lifestyle factors which can produce this hypertension as such. Now, if it is a stage 2 hypertension, again, the same protocol has to be followed. Ultimately, the need for a medical intervention up to stage 2 hypertension is limited to only these patients who have a risk of coronary pathology. Of course, stage 3 and below, above, naturally, patients need a antihypertensive therapy. It has to be treated with the pharmacological intervention. And interesting, though the guideline says that only a few of the patients need to be treated with the antihypertensive drugs, the antihypertensive drug market throughout the globe is increasing very rapidly, and the demand is increasing as such. Interestingly, whenever the demand reduces, then there will be a new theory coming up and a new drug introduced. So there is a lot of commercial issues as such. So we will not go into that part. Now, coming to the question of non-pharmacological intervention in hypertension, the standard. Now, this is all importance is these are all from the standard sources of information. The criteria, non-pharmacological intervention, the target is, first of the thing is to ensure that the patient's body weight is maintained on an average. By maintaining that weight or reduction of the body weight, you can reduce the blood pressure in a patient with hypertension by about 5 millimeters of mercury. And the idea is expect about 1 millimeter of mercury for every kg reduction in the body weight. So reduction of the body weight, again, it has to be done by diet and exercise, food and exercise. This is what the standard protocol would be saying. The next important would be about the healthy diet. Healthy diet, of course, is a standard DASH diet, is the diet against systemic hypertension. And the basic is consume diet rich in fruits, vegetables, whole grains, and low-fat dairy products, and lesser amount of non-vegetarian food. By this, you can reduce the blood pressure by about 11 millimeters of mercury. These are all diastolic pressure. This, whatever we are talking is about diastolic blood pressure reduction. And a reduced intake of dietary sodium. Another non-pharmacological intervention is a consumption of the sodium being reduced. Now, when I say sodium, it's not only the salt. Most of the junk foods, so that they would have some preservatives or some chemicals, taste makers like Ajinomoto, which are added, which can be a source for these electrolytes, not only sodium, which can increase the hypertension. And this again is quite important to maintain that total target goal of consumption of the sodium to less than 1,500 milligram per day in an adult. It's quite important. By that, you can reduce the blood pressure by about 5 to 6 millimeters of mercury. And the potassium consumption, most of a better source for the potassium would be the fruits and vegetables. And with that, again, you can reduce the blood pressure. These are all the standard non-pharmacological intervention of the hypertension. So the important is majority of the patients who are classified as hypertensive up to about stage 2, they can be managed only with these guidelines, and there is lesser scope for there is a lesser need for the medical intervention, pharmacological intervention. Now, when I say about that DASH diet or dietary approach for the antihypertensive drugs, this dietary approach to stop the hypertension, what they say is, again, this is again the standards which are given by the US National Institute of Health. The guideline is grains and grain products is around 6 to 12% of the total, 6 to 12 component of the total per day, servings per week as such. And fruits, it's quite significant. Vegetables, and important is fats and sweets should be very low, not more than 2 to 4 per week. This is what the guideline says. So selective diet as is one of the important factors. Food which has to be avoided during hypertension or to prevent hypertension are all sorts of junk foods and those where you will have high fat content. These are established dietary factors as such. This is about what the current concept is and about the hypertension as such. Now, with this background, we need to consider what Ayurvedic point of view could be. And quite naturally, Sushruta or Charaka might not have identified the blood pressure because at that time, the instrument to record the blood pressure was not there. So, idea of recording a blood pressure, idea of maintaining these categories of the blood pressure is not possible at all. And do not expect it from Ayurvedic point of view. So that's why for Ayurvedic practitioners, hypertension becomes much more enigma than the other way. Now, as far as our theory it's about the circulation is concerned, that is quite important. In Ashtanga Sangraha, as far as the Pranavata functions, Bhagavata mentions about one word, Dhamani Dharana. And Dhamani Dharana is, we can interpret as something supporting the blood vessels. Maybe it may be suggestive of the hypertension, which can be function of the Pranavata. And another important issue, which we Ayurvedic doctors should be always proud of, is the idea of a circulation is established or is mentioned in Sushruta. As when it is described about the Sapta Sira Shatani Bhavati, Siras are mentioned, the description of the Sira, where there are two categories of the Siras, Yabhi Idam Shariram Aramaiva Jalaharidihi, Kedaraiva Chakulyabhi. One set of the Siras, they will be providing the nourishment to the periphery, like a garden being nourished by the channels of water, or another set of the vessels or siras, which will be producing or directing the blood towards a pool, like a pond being supplied by the channels. So that idea of flow of the blood in two directions, and that's the real idea of the closed circulatory system. And this was mentioned in Sushruta, and unnecessarily or maybe unjustifiably, the credit of inventing the circulatory system goes to William Harvey in 1850s, whereas this was mentioned 5,000 years back by Sushruta. Moreover, Sushruta even describes about the Akunchana Prasaranadivihi Visheshehi. The flow of the blood is regulated by variations in the hydrostatic pressure, which will produce a pulsatile wave. And of course, so that's the quite important issue which we need to be proud of. Of course, most of the times we neglect that part even. Anyway, another important issue where our Samhitas would be referring about the possible interpretation of the circulation would be when the Vyana Vata function is mentioned by Bhagavata. The major function is Dhanena Rasadhatuhi Vikshepa Uchita Karmana. That Vikshepa Uchita Karmana, it could be interpreted as a movement, a function which produces the movement of the Rasadhatu in a proper manner. So that proper manner is the pressure, maintenance of the pressure asset. So there is a direct involvement of the Pranavata which maintains about the status of the vessels, and Vyanavata which helps in movement of the circulation or maintenance of that circulatory pressure. And as a result of that, the circulating fluid will be moving around in a uniform controlled manner and it produces the nourishment asset. Now that's about possible build-up or possible hypothesis about the circulatory conditions asset. Now as far as how to understand hypertension from Ayurvedic point of view, because before we go for the plan of management, we need to have some idea about the hypertension concepts from Ayurvedic point of view. There are a lot of views, so I will try to refer to those also, the different views. I have a view, and there could be many who may not agree with what we consider. The issue is, as I consider hypertension from my point of view, when I select and when I plan the treatment, these are all the basic issues which I consider. One is hypertension is a silent killer. So because the person has hypertension, that doesn't produce an immediate disease, it can produce multiple complications later on. And that kind of an idea is the basic idea of avarana. Vayu avaranas, avarana, vayu ajnataha, jnata vavatsram sitaha. When they remain there, existing in the body for a long time, they can result in prajnapi dussadhya bhavehu anupakramaha. So if they are not treated properly, that can produce a delayed complication. So among those diseases could be silent killers like diabetes, hypertension, all that. They are the complication of avaranas. So that's one of the primary issues. Now, which are those conditions which can produce as a result of the avarana? Hridroga, Vidriha, Pliha, Gulmu, AACHAARA, Ayurveda. These are all the possible different complications of the avarana. Among them, Hridroga is one aspect. This is one of the important issues. So among variable avaranas, we will come to that, which are the avaranas which we need to consider later on. I'll just deal with that part. So primarily, I would consider hypertension as one variable of the avarana depending upon the presentation as such. Or hypertension also may be interpreted as a jara vyadhi, because the most of these, one of the frequent complication of the hypertension is there would be a premature senility, and the total life expectancy would be reduced, which is the typical feature. So that also is another of the issue. That's about the possible theoretical assessment of the hypertension as I view. They, of course, they related to the in relation to the other views. I'll just refer to that later. What the other Ayurvedic scholars would be saying. It's not that I am right and the others are wrong. It's not that way. What I say is, this is what I consider, and I can use that in my clinical practice. These theories are used in clinical practice and I can see the results. Now, when it's a question of coming to the real-time treatment of a patient, in the current situation where you have a very dominant contemporary system, and there are people who always prefer to have that the other system as such, and when they come to Ayurvedic treatment, their views would be something different, and the situation where we deal with the patients also would be different, and hence we need to have a methodical approach which would be justified from the point of view of safety of the patient, and from the contemporary views we should not be targeted. So that's the exact issue, and from that point of view, to strategize the treatment, what I see in my clinical practice, among the patients whom I see about hypertension, the types of the patient, maybe somewhere I have just classified these into the groups, percentage value which I have given 15% and so on. It's not very rigid and very perfect calculation. It's about the rough estimation. The important is when a patient comes to you and when we record the blood pressure without a typical symptom of hypertension, the typical symptom of hypertension, I'll come to that later. So I would categorize as asymptomatic hypertension. And when I diagnose, that kind of persons are around 15% of the total hypertensive patients whom I see. So comparatively, it's one category, one major group. And another major group are patients who have typical standard symptoms of the hypertension. Typical standard symptoms of the hypertension, I'll deal with that later, giddiness and dyspnea and so on. And the patients who have not been diagnosed earlier and which I diagnose. So around 30% of the patients of hypertension, I get an opportunity to diagnose them as the fresh cases. Now, of course, this percentage of distribution may be varying from one practitioner to other, depending upon our image in the society. So this percentage value is not a rigid value. Just to have an idea of how to deal with the patients, I have categorized this. Then there will be another group of patients who are on the standard antihypertensive drugs, and somehow they feel like they have to change over to Ayurvedic medicine, though their blood pressure is maintained normal and there are no specific issues with antihypertensive drugs. which and that counts around 7%. These I usually consider these as the soda bottle patients. Soda bottle patients in the sense they may have a very positive idea to come for Ayurvedic treatment for a few days, and then later they may just have a different view. They are not very sustainable patients as such. Anyway, that's one category. Another category of the patients who are on antihypertensive drugs but not stabilized. They opt for Ayurvedic treatment. Of course, there we have a better scope. Naturally, there is a real need for Ayurvedic treatment as such. Then the patients who have an antihypertensive drugs and they have some obvious adverse effect of the drugs, and there is a real need for changing those drugs as such. That constitutes another around 5% of the patients. Patients who come with acute complications like severe coronary ischemia, that's around 10% of the patients. Patients with the severe coronary ischemia, and once they are stabilized, this is another major category. Majority of the patients whom I see in my clinical practice, and probably this may be true with the other Ayurvedic practitioners too, patients who had a stroke, patients who had some coronary accident earlier, and once they are stabilized, they may just seek for an Ayurvedic treatment as a supplementary. So we need to be aware of these needs of the people, and this is one major category. So among all the category of the patients, the major category of the patients whom I see would be around these, where patient had some either cerebrovascular accident or coronary arterial diseases, and they are stabilized with some other treatment, and they come for Ayurvedic treatment for those conditions as such. Then, of course, secondary hypertension conditions like the pheochromocytoma or renal pathologies, that's another category of the patients, hardly around 3%. This is what I see. Now, I have a strategy plan for these kinds of patients. Now, whether this strategy is perfect or not, that's a questionable one. But from my point of view, this strategy is justified from the point of view of safety of the patient and the maintaining the image of our science. If the patient has an acute end organ involvement, conditions like severe coronary ischemia, there is a limitation for standalone Ayurvedic treatment. So I may not prefer to maintain that patient only with Ayurvedic treatment. There has to be some combination. At times, the patients, we may not treat the patient, or at times we may treat the patient along with the other prescriptions, the contemporary medicines may be prescribed as per the need. Then patients who are on antihypertensive drugs with the stabilized status, preferably, I would prefer the patients not to modify. Suggest the patient, like, you maintain whatever the drugs you are taking if there is real need. If there is no real need, then I may stop those drugs. But I would be stressing upon the lifestyle modifications, exercise, the diet and exercise, which has to be done. With that, the drugs can be either reduced or the same has to be maintained. I may not preferably, I may not prescribe an Ayurvedic medicines unless it is absolutely necessary. Like many times the patients may not be happy if you do not use the drugs. That's otherwise. But otherwise, generally, I would prefer to avoid such patients with our Ayurvedic treatment asset. Then the patients who are on antihypertensive drugs and they have maybe complications like CVA, I would prefer to maintain the existing regime, whatever the antihypertensive drugs their patients are taking. Along with that, I would be planning the management on the lines of what we assess. Maybe like a patient with CVA, it could be some variety of Pakshagata, and maybe I may give the treatment which is of Pakshagata as such. Now, for the other category of the patients, a group, large number of patients are of asymptomatic hypertensive patients, where we need to build up an Ayurvedic concept. Virtually, it's quite difficult. A patient who has a symptom, we can definitely assess which could be the dosha involved, and based upon the dosha concept, we can prescribe a line of treatment. But in an asymptomatic patient, it's quite difficult to have a line of treatment. So what I have done is, I have just borrowed certain basic theories of or basic approaches of the hypertension management from the contemporary point of view, and I have found a Ayurvedic idea how to approach with Ayurvedic drugs, which I myself would say this is a corrupt Ayurveda. From that point of view, of course, the basic issue is, in general, when it comes to the question of pharmacological intervention from the contemporary point of view, the major group of the drugs or major target areas of the treatment would be, one group of the drugs would be producing some diuresis, So renal output would be fluid is excreted out, and hence the blood pressure is reduced. Another group of the drugs would be improving the status of the blood vessels so that the blood vessels will be dilated and hence the blood pressure is reduced. And of course, then there is a metabolic issues which can reduce the blood pressure. So these are the major three categories of the drugs which are used as antihypertensive drugs. Of course, there are many more. I'm not just saying that it's a complete one, but major is that. Now, in every patient of hypertension, there is a significant value for the lifestyle and dietary counseling. So when a patient comes to me, I would just give the patients a guideline about what should be the lifestyle changes and the dietary changes which are to be done in that patient, which is a major category. Now, to deal with this, like asymptomatic patients, where there is a need for drugs to replace that idea of a renal output, I would be preferring Punarna as a drug. And for the metabolic causes, I would prefer a Rasayana Aushadhis, and usually I prefer Chandraprabhavati as a Rasayana. Of course, any Rasayana Aushadhi can be helpful. And then for the stress and the vascular tone, because the vascular tone is often related to the stress, and reducing the stress can improve the vascular tone, I would prefer Saraswara. So, in general, in majority of the patients who are asymptomatic, I would not prefer a medicinal treatment unless there is some maybe psychological needs or the other way. But I would prefer the patient to maintain their blood pressure with lifestyle and dietary counseling and monitor the blood pressure. If there is the monitoring of the blood pressure, if there is not satisfactory reduction, I may prescribe these drugs. And what I have observed is a good number of patients would show a significant output if they follow that lifestyle and dietary factors as such. Now, coming to the other conditions where the patient would have a symptom as such due to the hypertension, among one of the common symptoms of these hypertensive patients are dyspnea on exertion due to the cardiac enlargement and cardiac load as such. I would consider these patients as an Udana Avrta Prana. As I have told earlier, I would consider hypertension as one variety of the Avarana. And when a patient comes to me with an Avarana, these symptoms of dyspnea, I would consider this as a Udana Avrta Prana, because the Udana Avrta Prana, the clinical symptoms are Nishwasa Uchhasa Samrodha. Samrodha for Nishwasa and Uchhasa, breathlessness on exertion. And then Hridrodha, the possible involvement of the heart. And based upon that, I would consider Udana Avrta Prana. And the line of treatment which I would prefer would be when there is, again, the basic protocol of suggesting about the lifestyle and diet is common for all category of patients. And my preference of the drugs would be Chandraprabha, Punarna and Avipattikara as such. Virachana often helps in such patients if the patient is fit. If there is not much of a severe cardiac enlargement, Virachana can produce a significant outcome. What I have observed is the results are not very consistent, not very dependable. Some patients respond well, some patients may not respond well. Particularly if the cardiac enlargement is higher and the thickness of the ventricular wall is more than 10 millimeters as such, seen under the echocardiography. So investigation of echocardiography is one of the crucial issues. Again, another one of the controversial issue, like when to decide the blood pressure when the patient needs treatment or not. Of course, in the contemporary system, this idea of assessing the ventricular thickness as a criteria now has become obsolete. But in around late 1980s, when we were studying, when I was a PG scholar, during that period, one of the important criteria to decide whether a patient of hypertension needs a treatment or not was based upon the thickness of the ventricular wall. If the ventricular wall is thicker than 8 mm, it was standard, at that time it was considered as a standard need for treating the patients with antihypertensive drugs, and usually the standard protocol would be giving some diuretic drugs. This is the this modern system as such, but now in the modern system, this idea has become somewhat obsolete. It's not a standard protocol practice now. they have changed that idea. Reasons, of course, is not the point which we are going to discuss now about the reasons, but that's the other point. But my approach to the treatment in these patients would be based upon the Udana or the Prana. Now, another major category of the patients who present with the symptom would be the giddiness as a symptom of hypertension. Patients who have giddiness and then we diagnose this as the hypertension. I consider this as a Pitta Prana or occasionally Udana. Because the Brahma as a symptom, it can occur in Pitta Prana as well as the Pitta Udana. Brahma is a common symptom for both. Udane as Brahmadeha, Brahma Murcha as the symptoms as. In these conditions, my prescription would be Chandraprabha, Kamaduga, and Punibadikwata. And interestingly, the results are more dependable. Patients will have better response, and particularly with the Virechana, the results would be very significant. So, one category of the patients whom I would prefer to treat, where I can almost definitely show the results, are those patients with the symptom of giddiness and patients who have hypertension without any acute complications. That's one of the area where we can really produce some changes as. Then the patients who may have transient ischemic attacks or neuritis, another patient category of the patients, particularly hypertensive patients, they may have peripheral neuritis symptoms, tingling sensation, pricking type of pain in the limbs, as or occasionally it's the ischemic attacks, pain in the chest, inconsistent coronary changes, which I will be dealing with later in the later half of this our presentation. And I would consider this as a Pitta Avarana Vyana. And in these conditions, a Avarana Vyana, I would consider these patients as I would prefer to treat these patients with the Chandraprabha, Ekangavira, or Manjastadikwata, or Ashwagandharisa, depending upon the situation. If the patient has a very burning sensation, severe burning sensation, I would prefer Manjastadi or Ashwagandharisa otherwise. And Basti treatment, like Matra Basti or Radhayapan Basti, also can produce a significant outcome. The results would be quite dependable, but at times, patients may require a support of other contemporary system of medicines, particularly like platelet aggregation inhibitors may be necessary from the point of view of safety when the patient has a transient ischemic attack. Then another category of the patient's symptoms, I don't say that it's symptom, but something like a coexisting factor. Patients with the hyperdyslipidemia, altered lipid concentration, or obesity. I would consider this as a Kaphavrata Udana or Kaphavrata Vyana or Prana. The Kaphavrata Vata Vyadhi, it's typical Udane Gurugatratvam, the Gurugatratvam, Arutihi, Vatsuragraha. These are the typical features which can be seen, or it could be the obesity, which is clinically visible. In these conditions, I would be preferring Chandraprabha Arogyavardhini Avipattikara as the choice of the treatment, considering this as Kaphavrata Udana, and Agni-Chikitsa and Ksharabasti or Matra-Basti. Now, Agni-Chikitsa is a unique this lepa of Prachana Dravyas, Tikshna Dravyas, which is used in our center, SDM center. Of course, it could be any of the other. So, Agni-Chikitsa is not a Samhitokta treatment. It's a treatment which we follow in our center as such. That's one which we follow regularly. And with that, you can produce a significant changes in the course of the disease. And instead of Virechana, I would bring a Ksharabasti or Matra-Basti in such categories of the patients. Then the other interpretation of the hypertension, some of the physicians consider this hypertension as mother. But really, that description of the mother is related to the hypertensive encephalopathy. Acute hypertension presenting with encephalopathy, it typically presents with the typical symptoms of the mother, where mother murcha, sannyasa, tesham, vidya, vichakshana. These are the possible complications, particularly raktaja mother. It can be related to that. And that condition is one condition where it may not be possible to manage only with our drugs because it is an acute complication conditions. I would consider that patient as beyond the scope of standalone Ayurvedic treatment. But along with other antihypertensive drugs, normal protocols of treating that, we can give our treatment also. And when it is managed with the our drugs, my preference would be, of course, it's quite true that it's not standalone treatment. The others established antihypertensive drugs are necessary. If necessary, a life support treatment like maybe the oxygen supply or IV fluids, depending upon the patient's condition, these are required. I will not go into that part in detail. Along with that, I would be preferring the treatment of Chandraprabha, Ekambira, Abhraka Basma, Tapyadi, Gondya, Pratikara, considering this as the remedy for the Marga Aranjanya, Athaprakopa. This is the usual prescription I prefer. And of course, invariably, there will be some other contemporary antihypertensive drugs given till at least the patient's condition is managed. Maybe gradually in due course of time, those antihypertensive drugs either may be reduced or stopped depending upon the response of the patient. Then Agnichikitsa and Matrabasti is the standard protocol along with that. Now, another major area where we can produce some changes is in the patients who come with the complications of the antihypertensive drugs. These to make it as a summary, the common complications of the different categories of the antihypertensive drugs. Beta blockers, the common complications are related to the bradycardia, hypotension, giddiness, etc. In that condition, I would be preferring to add Chandraprabha or Sarasudarista. Whether we can stop the beta blocker drug or not, that depends upon patient's response. Some patients we can stop, in some it may not be. So to have a generalized rule is quite difficult. So there has to be a regular follow-up with the patient, and then only we can decide like whether this is possible or not. So to say that it would be possible to stop those drugs is not a standard treatment, but wherever it is possible, it's possible. It can be. Alpha blocker drugs, again, it's the orthostatic hypotension. Like patient would have more giddiness, dizziness after this, tachycardia, vertigo. These are the symptoms of these adverse effects of those drugs. In such conditions, my preference would be Prabhakaravati Kumariyasa, which can help the patients in improving those quality of life. Calcium channel blockers, which are comparatively safer compared to the other antihypertensive drugs, calcium channel blockers produce lesser incidence of these adverse effects, and when they occur, it could be bradycardia, hypertension, tachycardia, etc. In such conditions, I would be preferring Aragyardin and Mengestatic Vata as a treatment asset. AC inhibitors, another category where the patient may have angioedema, dry cough, etc. Again, we can either replace those drugs and administer these complications can be reduced as such. ARBs are comparatively less commonly prescribed, and there it's the orthostatic hypertension as such. That's one. Now, from Ayurvedic point of view, another quite important issue is patients who are on statin as a prescription now is increasing very rapidly. Almost every patient above 50 is going to any cardiologist for any reason. Invariably, the patients are prescribed with the statin. Now, whether these statins are necessary or not, again, big question. Even the contemporary physicians, they may not agree with that. But incidence of the this statin prescription is rapidly increasing. And I say that the statins now prescribed like salt added in the food, in the kitchen. And that's one avenue where we will have a good opportunity from Ayurvedic point of view. In patients of hypercholesterolemia, instead of the statins, I would be preferring, I can definitely stop those statins as such and give Chandraprabha Aragyardin and Kumariyasa, which can produce a significant change in the lipid profile. Virachana can produce a decisive, remarkable change as such. And diet and exercise are quite supreme, so more than any of the medicines. So statin over prescription is one area where we can produce a significant change. Now, whether the statins really produce a protection against, give a protection against the coronary artery disease or not, it's still controversial. Even in the contemporary system, you do not have sufficient data. But why the statins are prescribed, that depends upon the maybe commercial interests. At the same time, there are the common adverse effect of the statins are the muscle aches and pains. Major category of the patients who come to us Ayurvedic treatment those patients who are having these muscle aches and pains, vague symptoms where there are no other signs. If you take a typical history, definitely the patient will be having some statin being prescribed. Different varieties of the statins are just overtaking market. So these aches and pains are one of the major, very frequent occurring incidences. Though the reported results in the contemporary may be much lesser than what we see practically. Then, of course, the other adverse effects are not so significant. I don't say that they are very frequent, but the other adverse effects of the statins also are well recorded. But one area where we can produce a significant change is the statin-induced myopathy, that muscle pain which is produced to the statin. And there, in such conditions, one sure-shot remedy is a Kaishara Mrityunjaya Sarista. It is considered as the Amajanya pathology. The statins, they are the ones which trigger the ama, and the treatment would be for Amavata as such. So my preference of the drug would be Kaishara Mrityunjaya, and this is one area where we can definitely have an extremely superior edge. We can definitely stop the statin, but there are certain patients who may not be ready to stop the statin because they are brainwashed. In that condition, let them take the statin, and particularly the other common prescription which they may have is vitamin D along with the statin. And very interestingly, vitamin D deficiency is triggered by the statin, and when they are given together, incidence of the myopathy increases. So that's the important issue. Anyway, that's about the major areas of the treatment of hypertension as I consider and in my clinical practice. Now, to a brief about what the other different Ayurvedic views on hypertension. There are, based upon many publications of Ayurvedic treatment, and people who use these words like Dhamani, Prapurana, Raktagata Vata, Siragata Vata, Avrta Vata Roga, of course. But I have considered Vyanabala. These are all the different terms used by different Ayurvedic scholars. I am not criticizing any of these. All of them are practically true. But I think there is a lot of issues, confusion about that. Ayush Ministry, our Ayurvedic Ayush Ministry, has published the protocol of the hypertension, and they used the word is Vyanabala Vaishamya, and then there is a detailed this guideline about treating Ayurvedic drugs as such, and the drugs which are suggested these are the drugs, Mamsyadi, Sarpagandha, Brahmya, and so on. Again, my purpose of referring to this issue is not to criticize. The only issue is there is a possibility of other alternative thoughts, and there could be an option of easier and simpler approach to the treatment with more academic idea than simply suggesting that one drug is specific for the hypertension. That's all the point. Now, the major issues of controversies and contradictions about the blood pressure management is one is the ideal target pressure. What should be? I will try to deal with this with the data as which is seen, how to predict the risk. And another is when say hypertension, whether the patient has to be on antihypertensive drugs for a whole life or not. These are all the controversial issues. Relationship, the dyslipidemia and hypertension and the behavioral issues, herbal drugs as antioxidants, these are all bit of the controversial issue. Again, I will not be dealing with them in detail, but it's quite necessary that Ayurvedic practitioners should be sensitized about these issues. Now, about the target pressure, what should be now after giving the treatment? What should be the target pressure? The guideline is that the target pressure would be less than 120 by 80, and the diastolic pressure is in that range of 80. Systolic pressure is 130 by 140. This is the standard pressure. Quite important is that if you reduce the target pressure, the hazard of mortality increases. Beyond that, see, if there is a over-energetic treatment, a patient with this hypertension, if you prescribe a drug and you try to reduce the blood pressure below this target level, and with what I have seen also, this is practically true, particularly when the diastolic pressure has been maintained at a level of less than 80, the incidence, less than 60, the incidence of the complications would increase. The incidence of the complication would increase much more rapidly than the incidence of the complication and the higher pain. This is statistically proved, and it's not my data, it's the data reported by established journals in publications. Now, lower BP may raise the death. These statistics also would say you have these references of these articles, publications. If the blood pressure is less than 120, the mortality death rate is increased significantly, almost doubles up. This also is quite important, and which is often neglected by many practitioners around that. Now, the another study, again, these are all the different studies which I have just summarized. Like by maintaining this diastolic, the pressure, target pressure, the ideal recommendations of the hypertension treatment by the guidelines, the standard major treatment group guidelines, which is quite popular now, is if the patient is now to avoid those errors of over treatment, these guidelines are prescribed, and these guidelines now, the current existing guidelines after 2014, is the diastolic pressure of around 90 can maintain if the patient is around 60 years or that younger age. If the patient is above 60 years, then the systolic of 150 and diastolic of 90 can be maintained as a target. Quite important, which are not really followed by many of the cardiologists now. But this is a universal standard guideline which is often neglected. But from Ayurvedic point of view, and when we counsel the patient, these guidelines are quite important. We should be aware of that. And for all adults with the diabetes or chronic kidney disease, again 140 by 90 should be the target pressure, not below that. That's the one issue. Now the next controversial is about whether the patient has to be treated with antihypertensive drugs in the beginning or asset, and what's the value of that standard pressure asset. Now this data, the table which I have shown, is by a publication by the Association of Physicians India, API, which has taken a survey of the popular practitioners of contemporary system, the other system, not Ayurvedic people. And you have the publication source. There is a lot of confusion among the different categories of the people. Of course, majority of the cardiologists would be considering 140 by 90 as the guideline, this standard asset, as the target pressure. And the others, number of these doctors, cardiologists, would have a different opinion. And moreover, the other issue, like whether the antihypertensives, once they have started, whether they need to be continued or not. There is another issue. Cardiologists, a good number of cardiologists, 50% of the cardiologists, they would say that they need to be maintained good, equal number of persons would consider a stopping of the drug. In reality, now this is about the cardiologist's opinion, family physician's opinion. From the same survey, from Indian point of view, the Indian practitioners as it, of course, my purpose is not to criticize the contemporary system, but what I would say is, always I would say, Ayurvedic practitioners are living better, have a better life, because the contemporary system practitioners, they do not follow the perfect guidelines. There is enough scope for our treatment, our involvement. So I think I'll not go beyond that. The other comments could be harsh, but that's a fact which we need to be knowing about. But the basic issue is that there is a prevalence of over treatment, and this over treatment can be definitely avoided, and the patients can be benefited from both the point of view, health point of view, as well as the economic point of view. Unnecessary medications can be stopped, and there is a huge scope for that kind of a modification. Now, the other issue, like echocardiography as a ventricular thickness as a guide for treatment, I think I have referred to that issue. Earlier, during our clinical study, this was one of the standard protocol, but now it is not changed from that guideline is changed, and the latest guideline doesn't refer to that issue. But what I have observed in my clinical practice is it's quite true and quite safe guideline, if the patient has evidence of left ventricular hypertrophy or atrial dilatation, even if the patient's blood pressure otherwise seem to be within that safe ranges, there is a need for antihypertensive drugs. If it is not, we can definitely avoid the antihypertensive drugs. So whenever there is a confusion, I would be always preferring to have an echo study and see the thickness of the ventricular wall, and I maintain that guideline, though this guideline now has become obsolete. Then as far as the other issue, like when a patient comes with the antihypertensive treatment protocols, usually come with the other prescriptions, modern drug prescriptions, and there are multiple prescriptions, multiple drugs given. Whether this has some advantage or not. Usually, multiple antihypertensive drugs may reduce the blood pressure much more than what is expected. There may not be a consistent effect as it. So, better to maintain the patient on a single category of the drugs, unless there is a real need. Very few of the patients may require multiple varieties. Then the other part is about the mood and the hypertension. I think that's one point which I have referred in the beginning. Like whether it is mental stress which produces hypertension or the hypertension produces the mental stress. This issue also is dealt with based upon the statistics. Now it is known that it's not necessary that a patient of hypertension should have a labile mood or the other way. So mood is not related as such. That's about the other issue. Then another of the issue is about the antioxidants, which have now become quite popular. Among the antioxidants which are used in the contemporary system, you have vitamin C, vitamin E, and so on. But from Ayurvedic point of view, you will have a large number of antioxidants, and there is a major publication where many of the herbs are considered or studied about these antioxidant properties, and particularly this text, this book is a very standard book which mentions about those antioxidant effects of the drugs, these daily used substances, and particularly spices used in the kitchen. Their utility is described in that book. So I would suggest this book as a standard book as well. That's about in brief about the hypertension and my views on hypertension. Next category of the disease which I am supposed to talk about is the coronary disorders. Now, coronary disorder and hypertension, they are very closely related, and quite frequently the hypertension is considered to be the cause of the coronary disorders. But it is not only the hypertension as a cause for these coronary disorders. Based upon the statistics, the dietary factors, they constitute the more major than the systolic blood pressure. Of course, the other factors which are known are the air pollution, tobacco, cholesterol levels, diabetes is, and then the body mass index, obesity. These are all the well-established causes for the coronary ischemic disorders as such. It's not that a patient with ischemia would always have a myocardial infarction. It can be of different degrees. Initially, once the ischemia occurs, simply because the perfusion would be lesser, patient may have minute changes in the heart which may not be seen in the beginning, which may not be identified as such. And then later it results in the metabolic disturbances, accumulation of acidic substances in the cardiac muscles, which again may be clinically either identified or clinically masked. But in the next stage, there could be a diastolic dysfunction. At that time, patient may have presented with the reduced exercise tolerance. Then comes the systolic dysfunction, where the patient's systolic blood pressure would be varying, and the patient may have giddiness and so on. Till these stages, quite important is, till these stages, ECG, electrocardiography, may not confirm, may or may not, confirm the existing disease condition, the resting condition. The patent diseases could be latent. So in these conditions, a stress ECG could be useful. But beyond that, once the systolic dysfunction has affected, like the ventricular output has become changed, ECG changes will be consistent. And then the chest pain as a symptom would be seen much later. So when the ischemia presents the chest pain, it's quite true that the patient has crossed these many stages of ischemia, which are preventable. So it's not that we depend upon the diagnosis only of the chest pain to make the diagnosis of coronary disorder. It's necessary to possibly identify these patients at an early stage, which is difficult, but it's quite necessary. And depending upon the stress factors, and most of these can be easily prevented by modifying the lifestyle factors. Then, of course, you have myocardial infarction and necrosis as well. Now, in the latent ischemia conditions, my prescription would be in the latent ischemia, normal resting ECG is normal, but only the stress ECG produces some changes, mild or moderate changes. Whether the patient would have a symptom like pain or not. My prescription would be, of course, one is the general diet and exercise. Among the exercise, pranayama is one thing which can produce a huge change in the total outcome. Pranayama has to be practiced regularly. Discipline in the practice is quite necessary. Virachana is another game changer, which also can produce a significant change in the outcome in the patients. Usually, my prescription, I would not prescribe the drugs regularly, but whenever there is a need for prescription, I will be prescribing Chandraprabha and Arjunarista in such conditions of latent ischemia as such. Important is latent ischemic patients, they can be managed without medicine in a significant issue. Then comes the patients who have a real cardiac pathology. The real cardiac pathology could be produced due to many causes. It's not necessary that a patient who has a chest pain or the cardiac pathology may have only cardiac conditions. It could be due to many categories. It could be vasospastic angina. The pain could be produced due to spasm of the blood vessels, and they constitute around huge number, 21 plus 17%. Vasospastic angina with the changes in the muscles, and vasospastic angina without changes in the muscle, where the spasm of the blood vessel is the common cause. And in such conditions, the vasodilators, drugs like nitrates, they produce a huge significant outcome. Whereas if there is a real vascular changes, where there is a abnormality of the circulating conditions, blood vessels in the muscles and muscle condition is affected, then the nitrates may not produce the same advantage. They may reduce the pain, but the patient may not have the advantage. So whether it's a simple spastic condition or whether there is a vascular involvement, one of the basic issues would be the nitrates can be tried as such. If the nitrates have produced a significant change, then it could be vasospastic. A patient may have an angina or chest pain even due to non-cardiac conditions, which also have to be evaluated clinically. Now, anyway, I will not go into that part in a more detail. But whenever there is a coronary artery disease, the coronary artery disease has to be understood under two heads. When there is a non-obstructive coronary artery disease or obstructive coronary artery disease. Non-obstructive conditions where there is no mechanical obstruction, but the vessels either are narrowed structurally, or it could be functional like a spasm. Now, non-obstructive coronary artery disease are the conditions where definitely yes, we can have a medical management, and the typical identification would be by the ECG changes, where the ST segment is depressed, and the angiography, you will see that the vessels are narrowed, perfusion is irregular, it's not uniform, but there is no specific block. Important is in these conditions, even contemporary system, it's non-interventional treatments, like interventions are not really suggested. Non-interventional treatment should be preferred over the interventional treatment like angioplasty or so on. They are not really necessary, they are not really helpful. They can be managed with a platelet aggregation inhibitors and the antihypertensive drugs like beta blockers or AC inhibitors, depending upon that. I would be prescribing Prabhakarvati, Arjunarista, and of course, the exercise and diet is very essential. But when we advise exercise in a patient with a coronary disease, quite important is to have a graded exercise. Never go beyond the physiological limit. And there, the criteria of the Vyayama mentioned in this Vagbhata, like Ardha Shakti and Nishagyaha. Ardha Shakti and the criteria of Ardha Shakti, like Shwasa and the Sweda. Important guideline which has to be maintained. So decide about the limit of the exercise in a patient. That guideline is a very standard, and rather it cannot be better, it cannot be improved upon. and that's the one. And Virejan also can help in the patient. And these patients, the prescription of platelet aggregation inhibitors and beta blockers, it's always necessary. I don't say that we can it's not mandatory, but it's always safer to continue with that treatment. So I would be preferring to continue those treatment along with our drugs as such. Now coming to the obstructive pathology, that's the area where we have a real risk. And in the obstructive pathology, causes for the obstruction could be many. It could be a blood clot, it could be some other, commonly it's a blood clot, or it could be a dissection of the mucosa and the endothelium may be dissected and it may produce a sudden obstruction. These are the conditions where the interventional treatment will be definitely beneficial. Characteristically, of course, clinically, the differentiation between an obstructive and non-obstructive is difficult in terms, but on an average, a patient who has repeated episodes of pain and the pain which subsides with the usual medical management and not very severe, doesn't result in an acute complication in the first episode, it's usually non-obstructive. Whereas a sudden onset of the pain or sudden onset of the cardiac embarrassment and ECG changes which are seen suddenly and ECG changes which tend to change rapidly within a few hours, like in a few minutes and a few hours, you can, if you follow the ECG repeatedly, if the ECG changes are rapidly changing, that's a definite obstructive coronary disease which can be made out clinically or with the ECG. Of course, angiography would confirm in a case of obstructive, you can see the real obstruction, a blockade of the vessel. In obstructive coronary diseases, interventional treatment can produce a significant outcome if it is done within 8 hours or 4 hours of onset of the lesion. If it is delayed, the advantages of the interventional treatment like bypass or plastic, so on, they also may not have a significant benefit as such, but this has become a fashion. Now, these days, this has become a standard as such. The issue is whether the patient of unstable conditions or non-obstructive conditions and obstructive conditions who are safe as such. Again, there is a statistically, it's now known that even non-obstructive patients may develop an acute complication anytime, and the risks would be equal in an obstructive and non-obstructive. The only issue is in obstructive conditions, the whole clinical outcome would be rapidly changing, whereas in non-obstructive, it may take more time as it. But with our treatment supplemented with the contemporary system, non-obstructive coronary diseases can be managed for a significantly longer period than the usual, whereas in obstructive, I would be preferring the interventional treatment and the contemporary treatment more preferable than Ayurvedic treatment. But once the patient comes out of that crisis, then we may think of our management. Now, once the obstruction has occurred, it can result in the myocardial infarction. Myocardial infarction is a situation where the death of the muscles have occurred and there is a irreversible pathology. Now, myocardial infarctions are categorized into 5 categories now, and of course, one more is a myocardial injury, which can be produced due to many other conditions, which will keep out of these protocols. The usual is a 5. And among them, the myocardial infarction during surgery, that 5, type 5, is no question of any Ayurvedic intervention in that condition because it occurs in the operating room, and this has a totally different outcome, which is not really a focus now. But because we are discussing about the classification of myocardial infarction, we have included that too. Then myocardial infarction of type 4, where the percutaneous coronary intervention are associated with that intervention. So myocardial type 4 and 5, this also is related to the intervention within the operating theater. So of course, from the general clinical point of view, I think this is a general clinical Ayurvedic point of view. These are not necessary issues, but for a cardiologist, these are important issues. From our clinical point of view, type 1 is a spontaneous myocardial infarction where there could be a sudden ischemia and there could be a sudden onset. It's often obstructive, sudden onset. These are the conditions where it will be difficult to manage with the Ayurvedic treatment or identify because it's the whole course is sudden. Usually, patients would be being taken into a intensive care unit, and there is a need to monitor the patient in intensive care unit as such. So, scope for Ayurvedic treatment is lesser. Whereas, but still, some of the patients can be managed to a certain extent with Ayurvedic treatment once the patient comes out of that acute observation phase. Type 2 is that condition where there will be a abnormal oxygen demand and supply, and hence there may not be a significant structural pathology. There could be an ischemia due to many other reasons, either like acute stress, physical stress, or hypertension, and so on. I think that is a condition where there is a scope for Ayurvedic treatment. Type 3, where there is a sudden myocardial infarction and sudden cardiac death, often occurs due to involvement of the conducting system. Virtually, there is very little scope for Ayurvedic treatment. So when I say Ayurvedic treatment and Ayurvedic treatment protocol, we are focused mainly on type 2 and to a certain extent on type 1 as such. Now, type 2 and type 1 again could be of different categories. In a type 1, it could be like there could be some rupture of the vessel and a spontaneous artery dissection or coronary embolism. Now, these three conditions are beyond the scope of any medical management. They need an interventional treatment, and interventional treatment is much better than Ayurvedic treatment or non-interventional treatment. Of course, to decide which is the real pathology is quite difficult. You need an angiography. So that's why the scope for involvement with Ayurvedic treatment will be lesser. If you have identified a patient as a definite as a vasospasm, of course, Ayurvedic treatment can be somewhat beneficial, but real incidences of such conditions where we can treat would be much lesser, because these differentiation needs a setup which is beyond the scope of Ayurvedic practice, and hence rarely real opportunities to treat these conditions will be much lesser. Type 2 is often related to a fixed obstruction, where there is an obstruction which has been fixed and hence it doesn't progress much. The tissues have adopted. That's a condition where definitely yes, we can have some changes with the Ayurvedic protocol of treatment. And then of course, without fixed obstruction as such. So primary differences between the obstructive and type 1 and type 2 myocardial infarction is type 1, the course is acute, whereas type 2, the course is somewhat gradually progressive. Patient may have an episode of pain which tends to be reduced, and then again there could be progression, and that episode of pain may not persist with the severe outcome as such. So in such conditions where there is a clinical confusion of making the diagnosis, ECG often can be confusing, though ECG has a standard protocol. I'm not going to deal with that ECG in detail, but the ideal would be to depend upon the cardiac enzymes, and a better diagnosis is done by cardiac troponin levels. And the troponin levels also give you an idea about the prognosis. Higher the troponin level, the risk is more. So usually, if the patient has a troponin level much higher, I would not deal with that patient in my clinical practice. I would be referring to that the cardiologist. So you have that facilities where the patients can be treated with the intensive care asset, which is beyond the scope. Only those patients with the lower troponin levels and obvious confirmed type 2 and rarely type 1, we can manage to a certain extent. As far as the incidence of type 2 myocardial infarction, it's because those type 2 are ones which we can treat. It's true that the incidence is not lesser, it's significant. Blue color graph, particularly in old age. Now, important is patients beyond the age of 75, the incidence of type 2 myocardial infarction is much more than the others. So, older age patients having myocardial infarction, there is a better scope for treatment. Younger age patients, there are the other issues also. One is type 2 is less common, and the scope for non-med interventional treatment would be lesser, and there is more sensitive issue. People in general will be more sensitive about a cardiac issue in a younger age than in the older age. So all put together, all that factors put together, opportunities to treat the patients of this category, younger age, in a myocardial infarction would be lesser from Ayurvedic point of view, whereas later part of life, you have a better opportunity as such. Though it's often considered to be a disease of the old age, when I say about the age as a factor, now currently the incidence of myocardial pathology in a younger age, particularly even below the age of 30 years, is increasing rapidly compared to last 2010 2015 in India. This is from the Indian data. 2010 to 2015, there is a significant rise in the number of these patients, younger age patients, developing myocardial complications, which earlier was not so common. So this is quite significant, a issue of concern where the importance of lifestyle and diet, healthy habits, these are to be discussed much more than really the treatment as such. Coronary vascular diseases are considered to be the major causes of the death throughout the globe, and even in India, it's quite true that they are the major causes of the death, and they are quite sensitive. Society is quite sensitive about the cardiac issues, and hence we need to be bothered about that. Now, when it comes to the question of Ayurvedic treatment, I would be considering these as the ischemic diseases as a Vata Jahruproga, where the Shula, Vatena Shulite Tyartham. The Shula is the major symptom, and along with that, there could be systemic complications of Akasmat, Dinata, Shokaha, and so on. Now, management, as I told you, the opportunity to treat such acute complications would be lesser, but in the patients who have recovered from the acute state or a obvious type 2 conditions, my prescription would be, one is there always has to be preference for the regulation of hypertension. If the patient's blood pressure requires some other supportive treatment, I would not hesitate to do that. Prescribe that. Platelet aggregation inhibitors also may be necessary, like salicylic acid or clopidogrel, they are necessary. They may be prescribed, or if the patient is on that prescription, I would not stop that. Lifestyle modifications, as we have discussed earlier, all of them are very critical and much more important than the medical intervention. And my preference in the medical intervention prescription would be Prabhakaravati, Chandraprabha, Ardhinarishta, Punarnamandura. With that, a significant change in the total quality of life can be achieved in such patients. And graded exercise, yoga are the game changers. They can produce a significant change in the outcome. Now, as far as a comprehensive management of a cardiac pathology, based upon the statistics, which are those components which are quite important, like whether it is a cholesterol reduction, blood pressure reduction, and so on. The study has shown like a decrease in the cholesterol level can produce a huge change in the outcome, as well as a decrease in the blood pressure can produce a change in the outcome. Stopping smoking, a person who has a habit of smoking and has a cardiac risk, stopping smoking can produce a huge outcome, change in the outcome. And maintenance of the body weight. And quite important is maintenance of average physical activity, dietary fruits and vegetables. So if these are maintained, the risk of cardiac pathology can be reduced by 90 to 95%. This is what the data says. So more than a direct interventional treatment, the better would be a comprehensive treatment to consider all these factors together. Now, the last point would be, it's not the major target, but a patient with the cardiac pathology can present with the acute cardiac failure, and there the life saving will be CPR, cardiopulmonary resuscitation. I think I will not go into the detail of that protocol, but every practitioner should be sensitized about it, should know the technique and protocols of CPR asset. So that's one point. Irrespective of Ayurveda or modern, a practitioner should be aware of the CPR techniques and the requirements. I will not go into that detail, like how to do that as such, but it should be known. Now, we should also be knowing, like Ayurvedic practitioners will not do that, but we should be knowing about the existing trends in the treatment. The interventional treatment in the coronary diseases is increasing rapidly, and it's becoming quite popular. Compared to a few years earlier, it's quite popular, and almost this has become a fashion. These days now, a patient of above 50 he would go for a coronary angiography, something like overhauling your vehicle engine. And they say that my heart now has become better. So this kind of an idea is existing there. And there is a lot of controversy about interventional and non-interventional cardiologists. Cardiologists have two groups now, interventional and non-interventional. And in such conditions, it's quite common that the patient may come to you for a second opinion. So we need to be in a position to give some definite opinion as such. This also, there is a commercial drive about this issue. The cardiovascular stents market is increasing very rapidly, and these days it has become a fashion. The issue is about the popularity of the interventional treatment has become very popular in the past 20 years from 1990 to 2017. The death of people, the cardiovascular death data, this is from the global data, and color, density of the color shows the incidence of the death. It's often claimed like there is a lot of huge money in that, and a huge outcome, change in the outcome is claimed as such, as far as the incidence of mortality due to the cardiac pathology is reduced. These are all the claims, but the global data shows now, I don't think that there is a significant change in the total color of the globe, world as such. Maybe some changes are there. This less dense color suggests about lesser mortality, high dense color shows about the high mortality. Some areas where some geographical areas where the incidence of mortality remains high even now, even after this development of this newer cardiac technology. Anyway, it's a question of believing or non-believing. Whether we believe that cardiac these interventions have produced a change in the outcome or not, it's a question, as a big question mark. Of course, statistics shows some changes in the outcome, but as far as the clinical practice is concerned, we need to have a view about this issue also. With this, I will not conclude like what would be the point guideline for such issues. When a patient comes to you, like whether a interventional treatment is required or not, we should be in a position to give a balanced opinion, and hence these are important. This data and the current existing facts are important. Now, to conclude the whole session, I think I have taken much more time than what's supposed to. Sorry for that. The concluding point is hypertension is an enigma, and a practitioner should be aware of the current trends. It's quite essential, and non-pharmacological management is always preferable over pharmacological intervention, and this guideline has to be followed to make the difference between an Ayurvedic doctor and a other way, and that would be the identity of an Ayurvedic doctor. And Ayurvedic principles of management can produce a significant outcome in the total picture of the disease condition and can help the suffering humanity. And there is, if possible, wherever there is a scope, a judicious combination of the current knowledge as well as the ancient wisdom could be giving a better outcome. With this, thank you all for giving me this opportunity, and I hope there will be some questions. There are some questions. I think I'm supposed to answer those questions. Huh? There are reference of basic life support and chest compression. Of course, chest compression as a treatment protocol, I don't think that there is any description in the Ayurvedic text as such. But idea of supporting the respiration is mentioned in Sushruta Samhita in the context of Ashmari surgery. In the Ashmari surgery, that acute pain producing a neurogenic shock is described. Hatavat lamba shirshaha. If there is a acute neurological shock, it can produce a situation where the patient would have a hatavat lamba shirshaha, but there is no specific type of protocol as far as I know mentioned in Ayurvedic text as such. Then there is another question: is there any drug like isosorbide nitric oxide in Ayurveda? See, I don't consider any Ayurvedic drug to substitute any modern drug, because the pharmacological approach of Ayurvedic drug is totally different from the contemporary system. So I would not consider that way at all. The question is about whether we can manage the patients or not. And my approach will be based upon the dosha conditions. As I already suggested about, when we consider the patient as a avarana, maybe pitta avarana or prana avarana, we plan the treatment and that can produce some outcome as such. Then there is some opinions like based of Brihatvata Chintamani, Vasanta Malati, of course, all those, I don't have a clinical experience of dealing with those drugs. My prescription usually would be limited to commonly used and economical drugs. So very costly drugs I may not prefer as such. So I'm not in a position to comment on those drugs as such. Then there is another question: uses of Punarnavati.
Maybe, sir, sorry to interrupt you. Maybe it's Punarnavadi Kada. That may be Dr. Vivek.
Maybe see Punarnava as a whole. Now again, I would be preferring Punarnava Mandura than Punarnavadi Kada. Anyway, it has Punarnava as a whole has a role, maybe with an idea of Shotagna or maybe diuretic. So from the contemporary point of view, it's as I told you that it's a corrupt Ayurvedic practice, maybe diuretic as such Punarnava, or it could be the Shotagna, Kapagna. So it may be. So it's true. Punarnava has a role. Whether it's a Punarnava Kvata or Punarnava Mandura, it depends upon your clinical experience and choice. Then procedure like Shirodhara and Thalam is considered in hypertension. Of course, it can be definitely yes. In particularly patients with the stress-induced hypertension, Thalam and Shirodhara can produce a significant change in the outcome. But what I have observed is those changes which are produced will be temporary for a few days, and then again there could be an increase. Whereas if the patient is treated with Virechana or the Basti, the outcome will be longer, prolonged. So that's what I have observed. So, and not that Shirodhara is no use, Shirodhara would be useful, but long-term outcome, Virechana is a better outcome than this Shirodhara. That's what I have observed. Then role of Lashuna and Brihatvata Chintamani. I think it's the same issue. See, I am not going to comment on those drugs which are used the other way. I would be speaking on only those drugs which I use and where I have a clinical experience. Then in vertigo Thalisadi Churna, there is one question like in vertigo Thalisadi Churna. I don't think that there is any issue about it. Context as such. See, Thalisadi Churna, primarily it's Kapagna, Kapaja Vyadhi, it's suggested. Vertigo can be even involvement of Kapha, but again, these are all the questions I think either beyond the scope of what we are supposed to talk as such. Then there is another question like Punarnavadi Kvata and in Udanavata Vyana. It's a similar question like Punarnavadi Kvata or Punarnava Mandura. I think that's the same issue. Then there is another question. In post-valvular repairs or with valve extenders, can tap Prabhakaravati useful? Yes, we have plenty of patients who come in that category where they have cardiac interventions, and then later, of course, the ventricular functions are not well. Prabhakaravati can produce a significant change in the quality of life. Now, in such patients who have already undergone intervention, my approach would be I would not stop those drugs which are necessary, particularly anticoagulants or antihypertensive drugs. I may not stop those. Along with that, I may prescribe Prabhakaravati. Now, when it is given, the quality of life improves. That much is certain. Now, whether it really increases the ventricular output or not, such kind of an objective study is not done. Then, sir, please show the chart on side effects of different antihypertensive drugs with the Ayurveda alternative. Okay, there is one request like the slide of antihypertensive drugs has to be shown. Okay, I'll do that. Then, how to approach hypotension? What would be Ayurvedic treatment? Now, this hypotension is again a confusing issue. There is nothing like a disease called as hypotension. hypertension could be produced only when there is some other basic abnormality. Patients who are in a shock hypertension, that the protocol of the treatment would be totally different. But hypertension as a disease is not existing conventionally, but in the clinical practice, of course, lots of people use that word, and it's a money spinning business. And those patients who are under depression, often they are suggested that they have an hypertension, and usually some tonics are prescribed. So I don't do that. So if the patient has a lower blood pressure as a normal physiological condition, it's better that it is maintained. And then when it comes to question of normal blood pressure, the whatever we say as normal from the contemporary point of view is based upon the statistics. Those who have some basic idea of the statistics, there is always a standard deviation in the statistics. Statistics, the normal value is considered by having that median value of a graph, dumbbell shaped graph. So anything beyond that standard deviation, we consider this as abnormal, which is not necessarily need not be abnormal. So there could be many people who may have a lower pressure or a higher range of pressure as normal, and hence to differentiate that would be quite difficult. And persons who have physiologically lower pressure, definitely there is no additional risk factors. Whereas the patients with the hypertension, they are needed to be treated because statistics say that there is a risk, as we have referred to. So as far as the hypotension is concerned, that's a myth as such, from my point of view. Then in case of hypertensive idiopathic changes, what will be the treatment? I think retinopathic, hypertensive retinopathic changes. Retinopathy, I don't think that we have any effective treatment from Ayurvedic point of view. I would always suggest the patients with the hypertensive retinopathy to undergo coagulation treatment or laser treatment, whatever that contemporary protocol would say. But in such patients, if there is a need for prescribing, I would be preferring to give triple or madhusulfide vyam nishi netrabalayata, a general broad out treatment about the improving the vision as such. It has helped a few of the people. I don't say that there's a standard protocol I would prescribe in that. So in patients with the hypertensive retinopathy, I personally in my clinical practice, I would not intervene much directly. I would give the patients, I advise the patient to undergo the contemporary existing treatment, which will have a definitely better outcome. Then is Sarpagandha beneficial? Again, another controversial issue. I don't consider Sarpagandha as a drug which can be used in hypertension based upon Ayurvedic theories. If Sarpagandha is to be used because you know about the reserpine as a content, as one of the ingredients, I think reserpine can be prescribed directly than Sarpagandha. Controversial issue. Again, I will not go into. It's not. I'm suggesting about the controversy. The issue is, see, Sarpagandha being based upon our text. The major use of Sarpagandha is in the context of Visha. Visha Tikitsa, Sarpagandha is there in the text. And based upon the Gunadharma of Sarpagandha, I don't think that it could be used for any Avaradana Vyadhi, maybe. But it's true that Sarpagandha reduces the blood pressure. I am not denying that fact. But I don't generally prescribe Sarpagandha containing drugs in the hypertension because, as I have observed, it produces the same adverse effects of the reserpine. Reserpine produces the adverse effect of a sudden fall in the blood pressure, increase in the retention of water and electrolytes, and the suicidal tendencies. Similar adverse effects are seen even when you advise prescribed Sarpagandha. Moreover, Sarpagandha also can produce the gastric irritation. That's why I generally don't prescribe Sarpagandha. But when I say this, I'm not criticizing the practice of prescribing Sarpagandha. Whatever I have shared is what I prescribe clinically. So from that point of view, I don't prescribe Sarpagandha as an antihypertensive drug. Then there is another patient. There is a patient with diastole 100 millimeters of mercury in CKD stage 2. What is the dravya used? If the patient has a CKD stage 2, it has to be treated more carefully. And my prescription in such patients would be Asanadi Patha, because I would consider this as a Madhumeha. CKD, I will consider this as a Madhumeha, the end stage of all the Pramehas. So my prescription will be Asanadi, Chandrapur, Punarnamandura, along with the antihypertensive drugs, because once the patient has reached that CKD stage 2, maintenance of the blood pressure has to be with the other contemporary systems. So contemporary medicines may have to be prescribed, or if the patients are already there, it's better not to stop that. Then in the case of more sodium retainment, how can we reduce it? I think, see, that sodium retention, if a patient has really high sodium level, the causes may not be only due to the diet. There could be some renal pathologies. So there has to be a detailed study of that patient. The cause for that has to be considered. And of course, the standard otherwise to reduce the sodium would be a diuretic. So diuretic can be prescribed the other way. And of course, Punarnamandura can be useful in that condition as such. It's not a very specific treatment for hypernatremia, but a patient of hypernatremia due to other causes has to be assessed thoroughly. We need to go into all the investigation protocol, and then maybe it could be one of the supportive treatment. Then T-wave suppression, what is the prognosis in a 55? See, I think it's difficult to answer. Like T-wave suppression is not the criteria to decide about the prognosis. A prognosis in general in a patient with hypertension, the prognosis is not good, or rather you have more risks in a patient with hypertension, and a T-wave suppression also increases the risk. The prognosis can be predicted based upon the extent of the damage to the heart muscles and the other factors. Like it's also related to the location of the infarction. If the infarction is in the conducting area, there could be a sudden death as such. If it is relatively in the inferior surface of the heart, there may not be any significant outcome. So to predict the prognosis in a cardiac pathology, you need to have a thorough assessment. That component, I think we have not discussed in detail because it will be beyond the scope as such. But the basic issue is one is the involvement of the conducting system. Patients who have some arrhythmias or fibrillations, there could be an acute death, acute complications, fatal complications can occur. So I would usually try to avoid those patients from our usual treatment protocol, because that acute sudden death would be emotionally quite difficult to manage. So such patients usually are referred to. If the patient is known to be hypertensive, old age, naturally all these factors will be adding to the negative prognosis. So to predict the prognosis is not a very easy job. I think that could be a better answer. Then there is another question like tachycardia in a 14-year aged male having related congenital problems, gene-related congenital problems. Can Arjuna will be useful? Congenital gene-related problems producing tachycardia. I don't know. So I'm not able to get this clear picture of what's really expected. That question. If you can give some better picture of that patient, I can suggest. But a tachycardia as a whole in a young age, causes could be many. We need to consider cardiac as well as non-cardiac pathology. Maybe as well as the clinical incidence is concerned, thyroid pathologies, maybe hyperthyroidism could be the more common cause for tachycardia in a younger age than really the cardiac pathologies. Of course, cardiac pathologies also can be that. So to give you a very pinpointed answer to that question would be difficult, I think. Then in angina, what is Ashukari Chikitsa? Rest is the most best important. In angina, the best part of the treatment is reduce the oxygen utility, and rest is the best part of the treatment. It's a standard, universal. The universal answer to that question, like in angina, which is the best treatment, Ashukari Chikitsa, rest is the most dependable and very effective part of the treatment. Then there is another question. Explain the possible cause of showing variations in systolic pressure in both hands. If there is a blood pressure variation in the left and right hand, I think it's not necessary that it's suggestive of an immediate risk asset, but it could be suggestive of abnormality of the aorta and aortic circulation. So, base of the aorta circulation. So, either that could be in patients with the dissection, it's quite common, but dissection is a very dissecting aneurysms or dissecting aorta is a very acute complication. Where you may not have much time to assess the blood pressure on both the sides. Theoretically, it is true. But otherwise, a healthy patient showing a variation in the blood pressure, it could be suggestive of some abnormality of the vessels, peripheral vessels. Often it's common in old age patients with the atherosclerosis. Circulatory pressures on both the sides may not be equal. But I think that's not a very huge issue, and usually the pressure is not more than about 5 millimeters of mercury.
So excuse me, sir. Sir, can I take the responsibility of reading the questions for you?
Okay, fine. That could be. I think I thought of this to save the time. That's all.
Yeah, I was very reluctant to interrupt you out of respect. But
fine. You do that.
Okay, sir. Sir, the next question is from Dr. Viraj Hegde. The significance of low BP with respect to coronary disorder and neurological disorders, diastolic less than 60 and systolic less than 110. How to manage? Dr. Viraj Hegde. The question was raised at 7:27 in the evening. Sir, are we audible to you? Dr. Vignesh, does anyone listen to me? Or is it trouble with the internet?
I think Sharma sir, his connection is a bit muted.
No, I think definitely there is some.
I think his internet got disconnected.
I think till he rejoins us, it was a great narration for us, not only medically but also tactically, in terms of whatever. I will just stop any moment, sir is coming back to us.
Sure.
So if somebody can call him.
I will contact him.
Yeah. Okay. So respected audience, I think we had a very great time. And we ourselves have our own mentors here in Kerala who have the habit of what we call as approaches which are very varied. As simple as Saptasaram Kashayam, Maharaja Prasanita Ilam capsule used by Dr. C.D. Savden sir, and Rasonati Kashayam is so common here in our tradition. The role of Talam that is so relevant, and Dr. Rajapal sir, late Padma Shri Dr. Rajapal sir, who was also an MBBS doctor, his favorite, the Bhela Churnam, and multiple such options, including the role of Talam that is so commonly used in systolic hypertension. And in the government sector, we have realized how even so-called structural aspects, which is diastolic, is attributed to, coming down up to 20 values in a span of 45 minutes using Shirabala Talam of the government supply of Aushadhi. So the varied experiences that come up, and one thing that sir really hammered in our mind was the point that not in every case or in every situation or every protocol the results being consistent. And this is the challenge we also face generally in our government service. And more importantly, sir has minced no words, and as direct as he is and as explicit he is, we have been very clearly communicated the market aspect of these drugs or the procedures or even the what we call as the politics behind all these, be it the standards of the blood pressure values, or be it the aspects of the protocols of therapy, including the interventional aspects. So I think this is something that we will have to fight it out. There is a politics behind it. There's a lot of strategic planning that is needed. And the kind of presentation Dr. Sharma has given us. Dr. Vignesh, please stop me any moment.
Sir's internet connection is disconnected. So he's trying to join from another connection. So he'll join.
Then I will carry on then.
Sure.
Any moment I will halt. So the very fact that he has given us more than prescriptions, and the very fact that the strategy has been conveyed to us, and there are many of the PowerPoints in this that we can always take a printout, and of course we can very humbly and gratefully acknowledge that this is from one of the best Ayurvedic brains in India. And all of us are aware of the fact that the prescription value, when I called Dr. Sharma sir to say a few words about him, he was very declining in the fact that he was not at all interested in telling any good words about him. I really had to put myself in control so that he doesn't get offended by praising him. And that is the kind of simplicity he has. So that's why not even 2 minutes, I just handed over the baton to him. But we have to keep in mind that the kind of practice he had, and with all respect to all the doctors of the Udupi Ayurvedic College, what I've been told by students of his, those who know him for more than 20-25 years now, that nearly 50% of the patients would be of Dr. Sharma sir. So that speaks automatically who created the patient base there. And his...
Sir is back.
Okay.
Sir is back.
I stop. Yeah. Sir, am I audible to you?
Now, I think, am I audible now?
Yes, sir.
You're more than welcome.
I think I think you can hear me.
Yes, sir. Sir, the last question was from Dr. Viraj Hegde, posted 7:27 p.m. about the significance of low BP with respect to coronary disorder and neurological disorders when the diastolic.
Okay. I think with the low blood pressure in a coronary disorder is always suggestive of a high risk condition. So if a patient has a coronary pathology, acute coronary ischemia, and then the blood pressure is low, it's a high risk condition. It needs to be immediately treated with the intensive care protocols. So I don't think that we can manage with any Ayurvedic medicine. So if a patient...
Sir, the next question.
Reduction of the blood pressure, the whole protocol would be emergency protocol. It has to be treated as an...
So there's a halt at your side. Sir,
So maybe it's better without the video, sir.
I'm not able to see the questions. If there are...
Sir, I will read that for you, sir. That's our responsibility. So maybe you can try without the video. Maybe that has a trick. Maybe may not be.
Okay, I'll wait. I'll cut off that.
Yeah. So the next question is, in a post-CVA patient male age 62 years, speech is disturbed, what to be done?
If the speech is disturbed, that's due to the involvement of the speech area in the brain. So it has to be treated in the line of Pakshagata. So my treatment will be of Pakshagata Chikitsa. You'll be using usually Ekangrira, Abrakatapyadi, that's the usual treatment. And then of course Basti is given, that's the usual treatment. So the whole approach will be Pakshagata Chikitsa, not related to the cardiac issue.
Sir, the left bundle branch block, 61 years, female, complaint of dysphonia, how to manage?
See, complaint of dysphonia.
How to manage? Yes, sir.
Yeah. Okay. See, bundle branch block and the abnormality of the speech, they are not interrelated. See, bundle branch block might have produced a neurological issue due to embolism. So that neurological issue has to be considered separately, and bundle branch block has to be considered separately. As far as the management of bundle branch block is concerned, it all depends upon the degree of bundle branch block. See, bundle in general, bundle branch blocks are risk conditions. Whereas AV blocks, safe conditions. So if there is AV block, I will be treating that patient safely with our drugs like Pravakaravati, Arjunarisa, etc. Bundle branch block, there is always a high risk condition. There could be sudden development of arrhythmias. So that patient has to be treated with caution. So I usually prefer to treat that patient on the contemporary guidelines, modern guidelines. So whatever there is, depending upon the causes. And one of the important general issue is that the ventricular output has to be maintained in such conditions. Bundle branch block can reduce the ventricular output. So we need to treat that patient, maybe depending upon the conditions, maybe the diuretic, antihypertensive drug, or other cardiac. At times, in a very severe condition, digoxin-like supplement may be necessary. So I may not have a standard Ayurvedic protocol for bundle branch block. But a patient who is maintained with those drugs and has a bundle blood clot, definitely I would be treating that patient with the Prabhakaravati and Arjuna Rista, which can help to a certain extent. But I don't say that a patient of bundle blood clot can be treated only with the Prabhakaravati and Arjuna Rista in general. I think that's a correct answer. Right.
Sir, I don't know if this comes in the preview of today's discussion, but anyway, the question posted is how to break a stroke in Ayu approach.
How to treat a stroke?
Yeah, it is written as break. I imagine it was meant as treat.
Okay, I think we have to follow the line of Pakshagata Chikitsa or Avarana. Among the Avarana, it could be the Majjavrata Vayu, Majjavrata Vata, or different varieties of Avarana of Vyanavata. So, depending upon that. So, in general, I make the category into two. One is Avrata and the Anavata. In the Avrata condition, I would be preferring Pajan Chikitsa like Agni Chikitsa. And in the Nirama conditions, or where there is no Sangha, then the usual Swedara Chikitsa along with our internal medications like Ekakavira is the usual prescription. That's in brief. That's beyond the scope of whatever we are going to talk today. Anyway.
Yes, sir. That's why I want to respect the enthusiasm, but at the same time we have...
Okay, fine. Okay. That's why I have given some satisfactory answer.
Yes, sir. Sir, troponin test predicts the stroke 100%.
No, troponin is not for the stroke, myocardial infarction. If the troponin level is raised, that's the golden standard as per now to make the diagnosis of a myocardial injury. So, level of troponin gives you an idea about the extent of injury and predicts the prognosis.
Yeah. So, 41 years male with triglyceride 300 mg, VLDL 42, known hypertensive diabetes, can we handle the case with Ayu medicines?
Definitely, yes. Only thing is we need to ensure that the blood pressure and sugar levels are maintained. Whether we can manage with only our drugs or not depends upon the lifestyle, dietary factors. So the most important part is diet and lifestyle. If a person can have a perfect diet and lifestyle, the need for medicine is significantly lesser. In general, among those patients who are on treatment for hypertension and diabetes, at least 60% of the patients can be managed without medicines. Only 40% require medicines. That's what I have stressed upon. Like there is always a over treatment and overuse of the medicines. And if we can do that, contribute to that to the society, it will be a great contribution and it will be recognized by the people as an Ayurvedic contribution. And that's what I always try to do with the patients. And of course, it's true that many patients may not agree, may prefer to continue those treatment. That's left to them. But I would be stressing upon the real this issue of clarifying the patients, like whether there is a real need of the medicine or not. And wherever possible, it's possible to reduce the burden of the medicine treatment. And that will be a huge contribution to the people. Right?
Sir, Drakshadi Kashayam can advise with Sarpagandha in hypertensive cases?
I think that kind of question I have answered already. Whatever I use, and we have discussed. Well, about the other medicines, yes, of course, all of them are useful. And it all depends upon the clinical experience of the person. Those who have used those medicines, they can comment on that. And when I use very limited number of drugs in my clinical practice, I limit my clinical experience only to those medicines which I use. So such questions, I think there are lots of such questions of that category. Yeah. I think that's the only answer to that.
Yeah. Can you please comment on the pulmonary hypertension in a hypertensive patient with cardiomegaly?
A pulmonary hypertension is not related to the systemic hypertension. That issue is totally different. And in a pulmonary hypertension, the most important part is to maintain the ventricular output. So, to manage only with the Ayurvedic treatment, I think it would not be possible. So, I would always prefer to either maintain the patient on other treatment. Along with that, we may give our medicines. And usually, I would prefer Shwasakuthara Punarnamatara as a supplement to the other coexisting medicines in pulmonary hypertension. But incidents or opportunities to treat that kind of patients are lesser. So most of the times, because it produces some acute issues, we may not have an opportunity to treat those patients. So pulmonary hypertension treated with Ayurvedic drugs opportunities are lesser.
Yes, sir. And any kind of drug interaction chances with our medicines and modern medicines when used simultaneously?
As far as I have observed with my prescriptions, I have not come across any such critical issues of interactions.
Sir, the Rasayana Yoga is useful in cardiovascular problems.
Of course, yes, Rasayana yogas are definitely useful. And best of the Rasayana is Achara Rasayana. So behavioral therapies, diet, exercise, that's the best of the thing. And among the Rasayana Aushadhis, Rasayana protocols, my prescription would be Chandraprabha. I use Chandraprabha as a Rasayana Aushadhi, a simpler, easily administrable Rasayana. The other Rasayanas also can be definitely useful, but only the issue with those other Rasayanas, they becomes a relatively complex protocol, but they are useful. So Rasayana definitely yes would be useful in any of these hypertension or coronary pathologies.
So there is another question about Sarpagandha, but I would conveniently skip that.
I think we have. I think I have tried to answer that.
I'm skipping that, sir, with all respect to the questioner. And how many days we can continuously use the Rasa Aushadhis? Is any gap required?
I think this is a very frequently asked question. I am in practice. I am practicing since 37 years, and I have patients who are using Rasa Aushadhis for equal number of years, 37 years, and they are perfectly healthy and no complications, no adverse effects. Rasa Aushadhis producing adverse effect is a myth only among Ayurvedic people. So only thing is, of course, the preparation, quality of the preparation, and the real need of the medicines are two important issues. There should not be unnecessary prescription, and then quality of the preparation should be proper. And this is true for any Aushadhis. It's not only Rasa Aushadhis. With the Kasa Aushadhi also, these criteria are true.
Sir, about Abhyarishta and Kasturi Gulika in hypertension.
I think it's a similar issue. Yes, so maybe or may not be.
So there's something with again Pakshagata, so I would just conveniently skip it because we are more into the cardiac idea. So with all respect to Dr. Sunina, I'm just skipping. And then approach to gestational hypertension treatment in third trimester.
Okay, see, that's another issue which I have really skipped intentionally. Gestational hypertension is one issue which we have not really discussed. From as far as my clinical experience is concerned, I do not treat gestational hypertension in my clinical practice because there is a lot of sensitive issue about the embryo and so on. But I have seen some persons who are treating with the Punarnavamandura and having some benefit, but I have not treated. So my clinical experience, if there is a gestational hypertension, I don't take up that case. So I would be preferring the patient to be referred to the other contemporary practice.
Yeah. So there's one Dr. G, prognosis of facial pulse. It's not part of our. I respect the questionnaire,
Okay,
but
I think
I'm not getting into that with due respect because seemingly out of context of our topic, seemingly. And Talam application, Brahma.
I think I have answered that part.
Yeah. How long to use Chandraprabha, sir? You have already answered that there are people using for so many years. So I think we would assume the answer is till it is needed, or whatever should be considered. How long to use Chandraprabha?
I think questions are over. I think we had plenty of questions.
Yeah. And so last one, have you tried Uruvasti in CAD?
Uruvasti.
Uruvasti. Yeah, Uruvasti, sir. Yeah.
I don't know. I have not heard of that. I have not tried it. Yes.
Yeah. So the questions are all the answers are all. Sir, just a curiosity from our side. We know that you're very famous for very low dose of medication. So Chandraprabha, how would you generally recommend? You would say 1 BD, 1 TD. How would be your approach?
The usual my doses are 1 BD or 1 TDS. Most of the times it's 1 BD. Yeah. I never go beyond that. Maximum 1 TDS, not more than that. Any of the drug.
Yeah. Sir,
and with that we can be satisfied.
Sir, do you hear us?
No, I'm able to hear you. I think Could you hear my answer?
Sir, maybe it's my problem here, but I think I at least missed about 8 seconds. Maybe it's my problem here.
No, I think the question was about Chandraprabha. No?
Sir, that was dose of Chandraprabha.
I think that's lower doses, 1 BD or 1 TDS. That's it.
Yeah. Sir, and I think we are all aware of the fact that your cost of prescription is amazingly, appreciatively low. That makes it such a universal acceptability in all spectrums of the economic class. And I think you have told me before a week ago that you maintain 400 rupees or below per month. So
yeah, that's true. That's true. I have kept it intentionally in that level, with an idea of reaching to the lower middle class.
Yes, sir, that is what exactly when we were sending across the information about your webinar, we were intentionally putting this thing across to everyone that per day prescription cost is less than 15 rupees since I got it confirmed from you. And I think that gives us a lot of confidence if somebody is doing for that long and with that clarity, then we have nothing else to think about. We just can copy paste as best is. But we don't know if there is an X factor that works in your favor that may or may not work with everyone.
I think there is nothing special about it. Okay, fine.
Yes, sir. Our seniors and our friends, and as we all know, our teachers are your students. So there is definitely a Midas touch to what you do. We all are aware of that. I think that's the goodwill you carry for so many years, and it may be more than just academic excellence. That's the impression we carry. We hope we are right, and you have very simply denied it with humility. We are very grateful for whatever you have taught us. And in your temporary absence of a few minutes, I was communicating to the audience that you have given us not only medical lessons, but also very critical or political lessons, or rather strategic lessons, which would be of great importance in our practice to face the reality of today's multiple stakeholders to the health of the public, where we have to be just not physicians, but to be smart strategic people to face the entire issue of medical or socio-medical political scenario that we see even the time of the corona time anyway. So I think we all owe a lifetime of thankfulness to you and for your teachings, and we should also thank the patients who gave you these lessons. Without them, I'm sure all of us are incomplete.
Okay, thank you.
I think all over to you. Yeah.
I think MD sir, any few words? Then we can.
Sharmaji, thank you for your 2 hours continuous classes. We are very much thankful. All area regarding most of the area are covered. I only one question, sir, regarding the post-COVID area. I know that is a critical side. Number of the drugs are using very badly. So can you give me a suggestion, the post-COVID area regarding the hypertension? We are facing huge problem now after the COVID area. So can you give me your experience, sir?
In the post-COVID cases, among those conditions which we treat now, which I have come across, cardiac pathology, particularly stroke incidents, it has increased with the post-COVID. And my plan of management would be otherwise as usual. In a case of stroke due to after COVID, I would be giving Arogyavardhini in extra. That's the additional medicine, Amabachana. That's the idea. Another common complication which I come across is peripheral vascular disorders after the COVID. And there I usually follow the line of Vatarakta, and now I have maybe saved a few limbs. I had a patient who had almost gangrenous stages after that, and with Manjistari Basti and internal medicine of Kaishara Gugula and Manjistari Vata, I could save the limbs. Then another incidence now which is quite increasing is diabetes after COVID. It's quite common, and particularly in the second this wave, common prescription was steroids, and steroid-induced diabetes is quite common. In the steroid-induced diabetes, Arogyavardhini helps a lot. So one common prescription in any patient with the COVID, either during COVID or later in the COVID, one common prescription which I would suggest as something broad spectrum would be Arogyavardhini. Even during the acute stages, it helps a lot. And to treat a patient of COVID, it's very simple. The usual Mrityunjaya Rasa Aragyavardhini would be quite useful. Of course, rest and diet is quite important. If a person takes rest and Landhana is followed, 100% sure there will be no complication. Even those so-called 5% complications which can occur in comorbid conditions can be avoided if you do that. But only thing is, there are a lot of legal issues, and the issues are made more complicated. So I'll not comment on that part. But there are patients who are ready to take our treatment, and in such conditions, with all that legal issues like having a record of the investigations and having a record of the these other precautions about the COVID prevention, I think we can safely treat the patients. I think that's the.
Thank you, sir. Very useful. We are all very thankful for you for the. We are also develop our confidence also for the future for the treatment. Not only all the participants, especially the youngsters. If give me one more question, don't mistake me. That is the present we are facing the Niruha Vasti area, sir. That is management. Niruha Vasti, that is Kashaya Vasti management sometimes, complication. So what is your experience of that last question? That is very useful because
complication. See, as far as I have treated patients with the Basti, the only complication which maybe I have met with the patients who have huge hemorrhoids or proctitis. In these conditions, often Basti may be producing the complication. Beyond that, I have not come across any of the complications. Then the issue is maybe about the quantity of the Niruha Basti. The quantity of the Niruha Basti, I'm not sure, but what I have heard is in Kerala they give a huge quantity. I'm not sure about that. But we generally don't go beyond 200 ml. So that's what we generally follow. And maybe I'm not sure about that. So, but I have heard that the quantity of Niruha Basti given is 400 plus in Kerala, I think. Is it true?
Yes, sir. More than 650 ml.
Yeah, sir. Sir, even 160. Yeah.
1 plus sir, we are sometimes we are using.
Maybe the
1048 ml.
Maybe that huge quantity may be one of the factors. I don't know. I'm not able to give a very definitive view there. Otherwise, I have not come across any major issues with the Niruha Bastis complications. Patients with the proctitis or hemorrhoids, of course, it can be. So before we suggest Niruha Basti, I would just have a rectal examination and then I'd suggest Bastis.
Thank you, sir. Thank you. Very useful.
Thank you, sir.
Thank you. I think I can leave.
Yes, thank you, sir. Thank you. Thank you so much.
Thank you.
Thank you.
Very beautiful. Very beautiful.
So, to all the listeners, the next week we have the topic clinical experience of Pakshaghadam by Dr. V.C. Deep. So, next Sunday onwards, we will resume at 10:30 a.m. as our usual Acharya Rasayana time. And thank you, Dr. Sreejit, for a wonderful moderation, and grateful to you. And thank you, MD sir, Ramanathan sir, for making this all possible. So, thank you all and see you next Sunday, and happy Onam.